what I plan to do is talk about red wine procyanidins initially and indicate how that is a sort of research philosophy has evolved out of that, which I think will progress to more important clinical trials. So I've got a number of conflicts of interest, but I don't think they affect my judgment. Anyway, there's lots of study about alcohol consumption and the risks of coronary heart disease, myocardial infarction, mortality from coronary heart disease. These have been something of interest for at least 30 years. And this data here is some of the more recent data from the EPIC study, which essentially confirms all previous studies. In fact, that in men, there's a reduction of coronary heart disease. However, as you increase alcohol consumption, there's an increase of other cardiovascular diseases, probably as a result of increased blood pressure. But overall, if you're a moderate drinker, 1 to 2 glasses a day of wine, then you will have a lower all-cause mortality on average. Now, this is typical data, and it's the sort of thing I looked at for many years. It was sort of frustrating all of the time. A lot of the data would be just based on alcohol consumption with little differentiation between different beverage types. Nevertheless, I think it's quite important to note things like the health professionals follow-up study, because often it's said there's plenty of other things that you can do to protect yourself from heart disease other than drinking alcohol. And this study looked at the incidence of MI in the health professionals follow-up study, and it looked at other lifestyle factors: BMI less than 25, daily exercise, healthy diet, which is clearly one high in vegetables, low in red meat, and being a non-smoker. And you can see if you have all of these habits, you can see a reduction with alcohol consumption, but it's very noticeable that if you're in this 1 to 2 drinks per day category with all of these behaviors, you actually have a greater protection from MI than having those lifestyle behaviors alone over here. So the question I was asking in the early 2000s was, does red wine confer greater protection from cardiovascular disease than other alcoholic drinks? And these were the questions I felt we had to answer. How does red wine reduce cardiovascular disease? What is the protective component? And are all red wines the same? And I was encouraged by studies like the Lyon Diet Heart study, which looked at the atherothrombotic events in patients, mainly men, that had previously had an MI. And what was very noticeable in this study, in a P2Y12 antagonist being part of evidence-based medicine, is that you had a 50 to 60% reduction in further atherothrombotic events if you consumed wine. All of the study participants consumed, those that consumed alcohol, it was primarily wine, and it was primarily red wine. So this was an important study in my view. And this was another important study, a Japanese study looking at dealcoholized wine, showing that you could improve flow-mediated vasodilatation by consumption of 500 mils of essentially a potassium-rich polyphenol drink. So what are the polyphenols in wine? These were the sort of questions we were asking. There's a mixture of procyanidins and proanthocyanidins. Procyanidins are a class of molecules that are mainly flavonols. They come from grape pips. The proanthocyanidins are also flavonols, but they're a more complex mixture. They include the procyanidins and other oligomers of these flavonols. They're the main component in most red wines, but their levels vary tremendously. The color in wine is due to the anthocyanins, and then there's also some minor polyphenols like quercetin and resveratrol. There's a lot being written and said about resveratrol, but most red wines don't have any resveratrol or have an insignificant amount. And if you have a thick-skinned grape, like a Cabernet Sauvignon, the levels of resveratrol are often undetectable. So to actually suggest that resveratrol was important in this equation of wine and health is completely flawed from the start. Our strategy was to try and find out what it was in red wine that was important for modifying endothelial function. And we used an old-fashioned approach. We just screened extracts of wine and purified by HPLC, screening on cultured endothelial cells, looking for effects primarily on endothelin synthesis. And this is a good model for doing all sorts of things in terms of the complexity of what you can do. How it relates to what happens in vivo is always questionable, but we've done experiments, proteomic experiments and microarray experiments using this approach. What we found, and we published in Nature in 2006, is the only active polyphenols we could find in wine, if you start with a red wine extract as your source of them, was oligomeric procyanidins. We purified a number of polyphenols, all of them on mass spec characterization were procyanidins, typically trimers to pentamers. And on the right of this slide, we have a tetramer, which has a gallic acid group at the bottom here. And that's typical of a red wine, great pip procyanidins, because they're often gallolated. Now, the main source of these is the pips. The levels in wine depends a lot on the vinification process. So if you have a short alcoholic maceration of pips and skins, like many New World wines, you'll have a very low level of procyanidins in the wine. But if you have a more classic, old-fashioned 3-week maceration that is typical in Europe, then you'll have a high level of procyanidins in that wine. And we found, and others have found, that procyanidins have an enormous number of actions on the endothelium. And these could be useful in treating endothelial dysfunction. They stimulate endothelium-dependent vasodilatation. They induce Cripple-like factor 2 expression, which is a key regulator of the phenotype of endothelial cells. It's induced by flow. It's an indicator in endothelial cells of basically of a healthy endothelium, a healthy phenotype. And in combination with induction of KLF2 expression, we see suppression of ET1 synthesis and upregulation of eNOS. We've also shown that there's a number of pro-inflammatory cytokines and pro-atherosclerotic genes are suppressed. And we also seen that you increase antithrombotic and thrombolytic genes and suppress pro-thrombotic genes. Now, all of these 4 bullets would actually be useful in treating endothelial dysfunction, but the fascinating thing about procyanidins is they do them all simultaneously. It's a very coordinated response. So the other thing that we were doing, I always was fascinated by quotations and history of medicine, and I decided to pursue a strategy based on a man is only as old as his arteries. And I decided to see if wine consumption might be influencing longevity in some parts of the world, because if those wines were different, we probably could recognize that in the lab. And so this was a question, are all red wines the same? And if you look at studies where they do categorize consumption of wine into white and red, that's about as far as they go. They don't go beyond classifying whether it's a typical North American red wine or a European red wine. These could be crucial factors in determining whether red wine has an actual health benefit. And the places I went and spent some time in Sardinia looking at the blue zone. This is this area of Sardinia with a high level of extreme longevity, had the highest number of supercentenarians in the world at the time I visited in 2002. And this was a fascinating place to visit because in the blue zone there aren't any hospitals. So actually they were living this long life without medical intervention. And I also looked a lot at France. On the y-axis, I looked at the level of early MIs in men or heart disease deaths in men under 65 years of age. And on the x-axis, 10 years later, I've got the data about the number of 75-year-old men in those areas. And not surprisingly, these are inversely correlated. Interestingly, the beer and the white wine areas of the north of France, lower longevity, higher levels of coronary heart disease deaths in young men. And then it's the southern, particularly the southwestern areas, have higher longevity and lower cardiovascular disease deaths. And all this research, we focus very much on trying to relate what types of wine were being drunk in this area, because typically in France, it's been traditional, you drink your local wine. That's very much the custom, that your table wine is the one that's produced locally. So if there was a connection between the type of wines that people were drinking and better health, then we might be able to identify whether that wine was an important component. And what was fascinating, we identified one area, Gers, and the surrounding area that had this grape that's not grown elsewhere in France to any great extent, the Tannac grape. And when we analysed these wines in the lab, we found that these Tannac grapes are very rich in procyanidins, as were the wines from the blue zone of Sardinia, the Neuro province area that we looked at. Much higher procyanidins than your average wine that you'd find at least in a UK supermarket. And this actually was an important observation. It suggested that we had identified a biological activity in wines, and we had found that the wines in areas of low heart disease and higher longevity correlated with the presence of that. So in summary, procyanidins are the main polyphenol in red wine, and they are present in sufficient abundance and produce many beneficial effects in endothelial function that could be cardioprotective. And we see wines with higher procyanidins in areas of low heart disease and higher longevity. So I've gone on to look a bit more at wines. This is data from about 800 wines, looking at the level of oligomeric procyanidins, trying to pinpoint other relationships. The one that stands out is the Sagrantino grape, but typically in Italy, this wasn't drunk as a dry wine until about 30 years ago. It was mainly drunk as a sweet wine without the tannins. So there's no history in Umbria, where this grape is grown, of consuming this wine to try and relate a health connection. But other tannic wines are present in various parts of Italy and in France. So what are the limitations of this work, and what are the unknowns? Well, to date, there's no data to support procyanidin bioavailability. Obviously, that's an important factor. But there's also no data when people do polyphenol research, not just procyanidin research, but in general, there's very little data that connects the identity of something in plasma with a biological activity. So there's still these questions to be asked and answered about what are the biologically active polyphenols or metabolites that are circulating. Also, the other question is, well, is there clinical trial evidence that OPC-rich products can modify endothelial function or produce other health outcomes? So rather than looking to say, well, we can't measure these in blood, are there interventions being done with procyanidins that support this connection that we found between high procyanin red wines and low heart disease and higher longevity? So it might be interesting to know that one of the sort of traditional herbal remedies for heart failure, Hawthorn extract, is a procyanidin-based medicine, if you like. And it might also be interesting to note, of course, that severity of endothelial dysfunction is predictive of mortality in chronic heart failure. So there could be a sort of direction there that suggests that this was useful in heart failure because of its procyanidin's ability to reverse endothelial dysfunction. So one would then immediately look to the biggest heart failure study that's been done in recent years, the SPICE trial, and see that there was over 1,300 patients randomized to 900 milligrams of this extract per day, which contained 100 milligrams of procyanidins, versus a placebo group. And in this study, there was no significant reduction in any primary endpoints, either first cardiac event or cardiac mortality. And the only statistically significant observation was that patients with an ejection fraction over 25% had a reduction in sudden cardiac death. Now, I think it's important to recognize the dose of procyanidins was only 170 milligrams, because when you look at this COCO study, another source of procyanidins that compares high flavanol cocoa, medium flavanol cocoa, and low flavanol cocoa, when you look at medium flavanol cocoa, 198 milligrams of procyanidins is only just sufficient to improve flow-mediated dilatation. And so that's a greater dose than the SPICE trial used for Hawthorn procyanidins. And in fact, you need to have about 520 plus milligrams to have the most profound effect on endothelial function. Another study using COCO showed that if you gave patients with coronary heart disease 516 milligrams of procyanidins a day, you saw a significant improvement after 30 days in terms of flow-mediated dilatation, and there was a significant reduction in systolic blood pressure. Now, the study we've done is at the London Chest Hospital, led by Rodney De Palma and Martin Rothman. We did a study of high flavanol dark chocolate in heart failure, because it's ethically more acceptable to give a chocolate product free of alcohol than to give a wine product. And in this study, we gave a gram of flavanols per day, which included 650 approximately milligrams of procyanidins. And this was a randomized crossover design. So 24 patients completed the study. They either had high flavanol dark chocolate for 4 weeks, followed by low flavanol dark chocolate, and then 4 weeks follow-up, or the chocolates were inversed. So after 4 weeks of high flavanol chocolate, compared to all the other time points, there was a significant reduction in diastolic blood pressure of about just over 4 millimeters of mercury. And there was a significant reduction in N-terminal BNPs in these patients. Now, these patients were optimized before enrolling in the study for at least 6 months on maximum tolerated NICE guideline-based medication, which essentially included ACE inhibitors, angiotensin receptor blockers, beta blockers, diuretics, and aldosterone receptor antagonists to stabilize them before they were entered into this study. So this looks like a very important observation from my perspective, that you could actually change cardiac function in patients with chronic heart failure. And how do I think this works? We got a drop in diastolic pressure without any change in systolic. Well, I think the most likely thing is, well, procyanidins themselves cause an endothelium-dependent vasodilatation, but I think in vivo what they may do is sensitize vessels to the flow-dependent vasodilatation, which in patients with heart failure is diminished. And so I think that's probably an important effect. And this results in arterial vasodilatation, which results in a drop in peripheral vascular resistance, and hence the drop in diastolic blood pressure. And with a reduced left ventricular afterload, that explains the reduction in N-terminal pro-BNP, but the consequences of the reduced vascular resistance is there's an increased cardiac output, and so systolic blood pressures maintained. So what do I think the future should be in this area? Well, I think, and perhaps not all of the speakers will hold this view, I think we've got to take a real evidence-based approach to whether we can use procyanidins or indeed other polyphenols in terms of managing disease or preventing disease. So I am an advocate for double-blind, placebo-controlled trials of procyanidins, but just to optimize further the optimal composition of these products initially, and then to use outcome measures that mean something. I don't think it's sufficient just to measure endothelial function. I think we need to have measures of blood pressure, or we need to have measures of N-terminal pro-BNP, as well as other measures of cardiac function, if we can conclude what the optimal dose is and the appropriateness of this treatment when you add it on top of other treatments. And we still need to work on the bioavailability, metabolism, and the defining what the adequate daily intake would be, at which point we can think about doing some larger scale outcome studies. Now, obviously, Mars with NIH in the US have already planned an outcome study with cocoa flavonols, so a lot of these suggestions might be preempted by that work. So that's all I have to say, and I just want to acknowledge the people that have worked on this research over the past 15 years, and I've had funding from Polyphenolics in California, from Ocean Spray, and also from Barry Callebaut, a chocolate manufacturer. Thank you very much.
Cardiologists to engage in nutritional related topics. We have to change this mentality, because when we have effective treatments, then we are morally forced to try to understand the mechanism and to try to improve and to build up on this. Related to this topic, I have no conflicts of interest. I have other conflicts of interest, but these are completely unrelated to this topic. So why are we here? Understanding the mechanism or the mechanisms underpinning the cardiovascular health effects of Mediterranean diets, because we have solid epidemiological and now clinical trial data with a reasonable list of biologically active compounds. Since I'm not sure that we will have other chances of reviewing the epidemiology, I would just say that in the case of Mediterranean diet, we have solid evidence from secondary and from primary prevention study. Secondary prevention study, the Lyon-Heart study by Michel de Lorgeril. Here you see the Kaplan-Meier curves of patients without events in the control arm of the Lyon-Heart study. And here you see the huge benefit that these patients after a myocardial infarction had by being put on a Mediterranean type diet. And then we have a solid piece of evidence also from a primary intervention trial, the PREDIMED trial carried out in Spain, where two regimens of Mediterranean diet rich in extra virgin olive oil or in nuts rich in monounsaturated fatty acids and in some polyunsaturated fatty acids deriving from nuts, achieved again this huge benefit compared with the standard controlled diet. So we have to address the issue of what are the active components, and this is not an easy question to address. We tried to write something based on the previous symposia that we had over the past 3 years, and this was a paper that was led by Ole Fagerman with Paul Hugenholtz and me as co-authors, in which we tried to explain the complexity of the topic. The complexities have to do with the myriad of details in the biology and the epidemiology of nutrition as related to the pathogenesis and occurrence of disease. These studies on nutritional intervention with disease outcomes are inherently more complex than studies of single variables such as drugs or devices. And nutritional studies almost always involve a very large number of food components and component effects on physiology, none of which fits very well with the idea of a single magic bullet or a single target mechanism of action. The example for this is the Mediterranean diet, in which you have or Mediterranean diets, as possibly would be better, more accurate to define. Because here we have diets that are poor in calories, rich in complex carbohydrates with low glycemic index, rich in fiber and vegetables, rich in alpha-linolenic and in some areas also of fish-derived long-chain polyunsaturated omega-3 fatty acids, eicosapentaenoic, docosahexaenoic acid. Usually they are rich in oleic acid from olive oil, associated with a moderate consumption of alcohol, especially from wine, and rich in antioxidants from extra virgin olive oil and red wine. Examples of these are quercetin, hydroxytyrosol, elenolic acid, red wine, and also you heard about the procyanidin that Professor Corder highlighted before. I would like to focus on two of these components to make the statement that we are not looking for one single magic bullet, but probably we have to look at more components acting together in concert. Let's take the example of olive oil and the component of olive oil which is oleic acid. Oleic acid itself may work, according to the best of our understanding, at least through two important ways of action. One would be by competing with saturated fatty acids in the diet, and you know that dietary interventions compared with pharmacological interventions are different because you are not dealing with minute components. In this case, you have the problem of the zero-sum effect. So when you add oleic acid, you usually have less of saturated fatty acids in the diet, and this change of the balance may lead to a quenching of reactive oxygen species, as I will explain in a minute. And then we have effects on the procoagulability of the blood, on the tendency to thrombosis that we have in the postprandial period when we have an increased amount of saturated fatty acids in the circulation after a fatty meal. Regarding the first of these effects, here you see an example. These are monolayers of endothelial cells that have been primed with an inflammatory cytokines, in this case TNF-alpha. This is the reproduction in vitro in a very simplified system of a pro-inflammatory stimulus. And you see the intensity of the color here practically reports on the generation of reactive oxygen species, mostly hydrogen peroxide in endothelial cells, which are reported by the green dye dichlorofluorescein diacetate. And you see here that if you pre-incubate these endothelial monolayers with oleic acid, or even more with the polyunsaturated fatty acids, docosahexaenoic acid, you have a quenching on the production of reactive oxygen species, meaning in practice that you put a brake to the pro-inflammatory machine that leads endothelial cells to express addition molecules, chemokines, chemoattractants, and all sorts of pro-inflammatory mediators that endothelial cells produce when they are exposed to an inflammatory cytokine. But also oleic acid has the effect of quenching the postprandial thrombotic state, which has been studied and interpreted mostly in terms of increased levels of factor VII antigen and activity, procuring a pro-thrombotic state, driven by the intake of saturated fatty acids and correlated with the increase in plasma triglyceride, the so-called postprandial hyperlipidemia. And diets rich, in this case, in monounsaturated fatty acids, such as oleic acid, sharply reduce the ability of VLDL and, mostly important, chylomicrons that are introduced, that are elevated acutely after a fatty meal, to promote the cleavage of single-chain zymogen factor VII to the active dimer factor VIIa, So there is a quenching on the procoagulant activity of the blood that occurs in conditions of supplementation with oleic acid after the introduction of a fatty meal. And this leads to a less thrombogenic blood. I want to turn on the attention now to the other component, which is the polyphenolic antioxidants of extra virgin olive oil, on which we did several studies in the past years, mostly concentrated on some of the most abundant components, for example, hydroxytyrosol and oleuropein that are rich in olive oil, but also quercetin, resveratrol that are rich in red wine that, as Professor Coder said, is an important epidemiological correlate of decreased cardiovascular risk up to a moderate consumption. And here you see, in this case, that also in this case you have an effect of quenching of reactive oxygen species. Same system as before. Here you have control endothelial monolayer in which very little reactive oxygen species are produced. In this case, you prime the cell, in this case with formol myristate acetate, but practically you can do it with an interleukin-1, TNF, and so on. And here you have the effect of oleuropein, resveratrol, hydroxytyrosol, and quercetin, a quenching on the production of ROS. And this can be reproduced with a number of pro-inflammatory, pro-atherogenic mediators of endothelial cells, including, for example, matrix metalloproteinases, in this case MMP9, shown here in terms also of activity of MMP9, which can be involved in not only in the proliferation of vessels, in angiogenesis, but also in the production of a more fragile atherosclerotic plaque, more prone to rupture. The last piece of evidence that I want to draw your attention on is the fact that these components that I have highlighted do not act alone. And we can have now solid evidence that the effect of one component can be at least additive to the effects of the other component. This is a study that we published only a couple of months ago, and refers to the regulation of adiponectin expression by human adipocytes, by a line of human adipocytes called the Simpson-Golabi cells, under the effects of oleic acid and one polyphenol of the Mediterranean diet, in this case hydroxytyrosol. The simple background for this is that, you know, obesity is associated with an increased risk of cardiometabolic complications, including type 2 diabetes and cardiovascular disease. Obesity is characterized by an aberrant production of adipokines, some of which are here depicted, mostly TNF, for example, from adipocytes and from infiltrating macrophages, but also obesity and the pre-diabetic state is characterized by a decreased production of the anti-inflammatory cytokines adiponectin, which is a major adipocyte-secreted cytokine abundantly present in the circulation of healthy humans, which exert anti-diabetic, anti-inflammatory, and anti-atherosclerotic effect. And here you have a system in which you take these human adipocytes, you can see what happens if you put them in an inflammatory milieu, and then you can look at how the Mediterranean dietary component can modulate the change in either pro-inflammatory or anti-inflammatory cytokines produced by the adipose tissue. So here we have the system. There is no effect of these substances whatsoever at any concentration up to 20 micromolar, which is considered a nutritionally still relevant component when the cells are not primed with a cytokine. But as soon as you put TNF-alpha in the system, you have a decrease in the production of this anti-inflammatory cytokine. And here you see a concentration-dependent effect of hydroxytyrosol alone here and of oleic acid alone, which means that you can revert the unfavorable pro-inflammatory phenotype of these pre-adipocytes primed by TNF-alpha when you have exposure to these Mediterranean dietary components. What is interesting and what is the novelty, I think, of these findings is that when you add together oleic acid and hydroxytyrosol together, you can have an at least additive effect, as shown here in terms of adiponectin protein and in terms of adiponectin gene expression as measured by messenger RNA for adiponectin, as shown in the lower graph here. And you can go on trying to investigate the mechanism by which this occurs, and this occurs by an additive attenuation by hydroxytyrosol and oleic acid on the phosphorylation of some mitogen-activated protein kinases, in this case J and K, that are practically transducing the machinery of a pro-inflammatory cytokine in adipocytes as well as in endothelial cells. And in this case, you have an attenuation of the expression of the activation of these MEP kinases by this Mediterranean dietary component. So the working model that we have... yes?
Can you make it in 2 minutes?
Yes, it's finishing. The model that we have here you have the cytokine, the pro-inflammatory cytokine that tends to activate the intracellular machinery with the reactive oxygen species, turning on the production of MAP kinase and then producing the effects on suppression of adiponectin expression. And here you have the concerted mechanism of action of oleic acid and hydroxytyrosol. Therefore, and this will be my conclusion, multiple mechanisms of action of natural dietary substances in Mediterranean diets, mostly related to their ability to inhibit gene expression of pro-inflammatory genes or promoting the expression of anti-inflammatory genes. And these inhibiting factor 7A triggered thrombosis and inhibiting also arrhythmogenesis in the case of omega-3 fatty acids, not looking for one single silver bullet, which is a major variance from most current examples in cardiovascular pharmacology. Yet, I surmise to your attention, a quite important and possibly the most important weapon that cardiologists today have to make a population impact on cardiovascular disease. And this is the driving force that should keep our interest very much attentive to this kind of mechanism and to this type of treatments. Thank you very much for your attention.
Well, that's his introductory slide, and mine is very much the same, but it's a talk from the point of view of the clinician. And I hope I don't get his slides now. Nothing to declare. Okay. This is the kind of slide you've seen around, in that we have not at all solved the epidemic of various cardiovascular disorders, and I'll be talking about atherosclerotic vascular disease only. Actually, annually there are not 2 million, but 4 million citizens that die prematurely, at least a half of them recently women. The cost to the economy is huge. Worldwide, the situation is even worse. And there has been one advocate of an extreme way of solving it, namely that we should go and, in retrograde fashion, to you are what you eat, but you should eat what you ate. Professor Mesquite from Groningen is the one who heads the paleo diet movement, and he concludes that we really should look at the components of the Western diet. This is a slide from Professor Hu, who points out that it's not just Europe or America, but the rest of the world where the disease is grown. And if you had been in the previous session here, you had heard how far that is already spreading. This model I like to show. It comes from a paper in the New England Journal of Medicine, because as often as I go to these meetings, people interpret the disease differently. They look usually at the far right side, and they look for stents, magic solutions with surgery. If they go to pediatric cardiology meetings, they know that people are interested to the left of your picture, namely, how long is the coronary artery of a child still normal? And I think we should really look for the early plaque, which is the most difficult thing to do, because you can't see it. So I will be talking largely about factors that we might detect and might modify in order to be at the middle stage to defeat the early plaque before it becomes hemodynamically significant. This was for me the trigger into the polyphenols, a slide that shows that Jean, on your left, was eating very happily in certain arrondissements that Professor Corder also studied or looked at, whereas on the right-hand side we have Joe, who is still suffering from his Coca-Cola, and despite all good promises from McDonald's, although recently it seems to have been changing somewhat, are destroying or impeding the life of Joe. Now, in this picture, which I'm sure Professor Corder remembers, we see Jean Calment, who was one of the people living in a certain arrondissement in the Val de Gers, and who went on to become 122. I take the picture not because I think everybody became 121, but you can become older and you can remain very healthy. These are her daughter and grandchildren. The other change in my life was the papers that were published by Russell Ross in the American literature, which started changing my thoughts, because I had been taught lipid is everything, that causes coronary artery disease, and here was a pathologist, a very well-known man, whom I visited a number of times. He said it's utterly nonsense. It is not an accumulation of lipids, it is an inflammatory disease. Not very many people believed him until the Nobel Prize became more known, who was given to Furchgott, Inyao, and Murad, for their discoveries of the nitric oxide as a signaling molecule in the cardiovascular system, supporting the idea that the endothelium is not anymore a layer of passive cellophane, as was the thought until around 2000, but really a very important organ that controlled, as the maestro, other players in the orchestra. To me, as a clinical cardiologist, that was an eye-opener with all the previous slides, so that when the paper came out, but Peter Libby in atherosclerosis, in the Scientific American, where I read it first, and then I went back to Circulation, saw that the original paper was. These guys started saying there is really nothing else but infection and inflammation, which is at the dominant cause. It took the European Society of Cardiology, in its wisdom, until 2007 before we got a paper on this program. And in the session, Wine, Alcohol, and Cardiovascular Disease, Folklore or Facts, I hope today that we are a little further, there was the first paper by a certain gentleman, Ramon Estruch, who talked about alcohol, polyphenols, inflammation, and atherosclerosis. You all know what he has done subsequently. In that paper, which was in volunteers, he showed that in these normal volunteers, and I'll leave it up to you to guess who they were. Anybody want to read? The assistants in an academic hospital, as per usual. They could demonstrate in these normal people that when you give the red wine from Father Estruch's winery, you could suppress high-sensitivity CRP, fibrinogen, VCAM, ECAM. In short, even so-called normal people have a certain degree of chronic or acute inflammation. On the basis of these results, we went into a trial in Holland, in Amsterdam, which subsequently was dubbed the PRIME study. It was on polyphenols from red wine remnants, powdered, in patients with a metabolic syndrome and endothelial dysfunction. It took a number of years to conclude. We had a whole lot of parameters to measure, and ultimately it turned out that MCP1, at the lower length circled on your right, and MIF were the only two values that really were abnormal and were normalized when these volunteers with the metabolic syndrome were treated. And I would like to go a little deeper in the words that are written on this slide, because I have not heard them at this meeting or previous meetings. Still, I think they're terribly important. These are, first of all, MCP1, monocyte chemoattractant protein, which apparently attracts monocytes to the sites, the primary injury of the endothelium, and as such later experimentally was shown to be associated with cardiovascular disease. And if you, in animals, block it, you can reduce atherosclerosis. And in retrospect, when McDermott looked at the Framingham study, it turned out that on the blood that they had taken way back in the Framingham study, it was MCP1 that was elevated in those people who subsequently got the myocardial infarction. You can call this serendipity, but it's still a very interesting fact. MIF, macrophage migration inhibitory factor, is also associated with the onset of atherosclerosis. And if you block it, like its predecessor, you can make pre-existing plaques go back. And Bernhagen, quite recently, the professor in Aachen, has mentioned MIF as probably a much more important clinical parameter to measure if you want to find out whether your patient has the beginning of an atherosclerotic change in an otherwise normal artery. The experimental evidence subsequently was wonderfully supplemented by a paper that came from Italy, from the group that Raffaele has been associated with, and they took the umbilical artery at birth, I presume after permission, from the mother or the baby, whatever, cultured endothelial cells, human endothelial cells, and then measured a number of extracts from the Primitivo and the Negro Amaro grapes from southern Italy, and demonstrated the very parameters, agglutinins, that I had mentioned before, and shown that these could be very clearly, significantly downregulated already at a very low dose. So this is, in a way, the invention from the Gers, from Madame Calment, and Professor Corder's observation in human arteries of the umbilical artery origin. I put all of that in a series of cartoons because that, I think, is the easiest way. You see the endothelium, you see the leukocyte, it's sort of like the police officer walking by in the serum, and he's attracted to what is going on the surface of the endothelium by VCAMs, other agglutinins. Once the attraction is so great that the white cell becomes really attached, first by an agglutinin, but later even by invading the endothelial layer, the onset of a plaque can be demonstrated. Now, I believe, and many people with me believe, that the red wine, polyphenols, mainly the red wine, can block MCP1 MIF, as we showed in the Amsterdam study. So we believe that although this does not have full proof that we can do something about atherosclerosis, we can slow down the initial inflammation of the endothelium significantly, and that's now proven in other human cells as well. Okay, the rest is easy. If you can stop this agglutination, then the cells will hopefully resolve. If that's not the case, they become adherent, and from adherent they started to penetrate, transmigrate, and the plaque is being formed. This beautiful picture made by Curtis in 2009 shows this process once very clear. On the inside, you have the endothelial surface in white. You have the muscle layer at the bottom, And then if you look at the left corner, you see that first moment is when the monocyte can actually enter into the endothelial surface. Oxidized LDLs follow it, may be preceded. That's not very clear. I don't, from what I read, not believe it's so much the oxidized LDL, but rather an other inflammatory process. And then with the various processes, you see the action that polyphenols, such as resveratrol particularly, can have in fighting the reactive oxygen species, restore the function of the macrocyte, and let the macrocyte do its job by taking all the stuff back to the liver to inactivate it. This primitive picture is the fundamental. So if the PRIME trial has shown that the pro-inflammatory cytokines MCP1 and MIF can be slowed down and actually normalized, then you can say that red wine polyphenols reduce the adhesion and arrest the primary inflammatory action of these monocytes. And the thought comes, could this be something we should consider in our fight against atherosclerosis? Don't forget, this is a food component, not a farm. And along comes the famous EPIC trial. All of you have hopefully read it. It's a European prospective investigation into cancer and nutrition, originally conceived to find whether or not food, and particularly fruit and vegetables, could do something for cancer. It was then, when no evidence was found, transferred to the heart. And in 8 years, 8.4 years, all the countries in that colored panel, nearly everybody in northern, western Europe, but the Greeks are included as well, have delivered 313,000 men and women to look at what the effect of portions of fruit and vegetables would show. And you see here that up to 5 to 7, we have a marked reduction in the hazard ratio, and this was fatal coronary artery disease. And the portions you have to consume are 80 grams. So take the middle of 6, between 5 and 7, 6 times 80 is approximately 500 grams of vegetables daily. The cardiovascular disease then is, after all, being the most common cause of disease and death, prone to reduction once you do systematic what this study has done. In the last line of the paper, there's a very interesting comment, which I'm sure Professor Corder will subscribe to, whether this association is causal, and if so, what the biological mechanisms are by which fruits and vegetables operate to lower ischemic heart disease remains unclear. It should be also atherosclerotic heart disease, but okay. Then we had what Rafael already referred to, our PREDIMED trial. Again, a trial in Europe. This was prospective, a little bit scientifically higher up than the EPIC, but it still was not totally, shall we say, evidence-based. It did show that there was a marked reduction, again, in mortality, and this was particularly prone for those who took 4 tablespoons of olive oil. The study was terminated prematurely, after approximately 5 years, when there was a 30% relative risk reduction in these clinical endpoints, very much confirming the evidence from the previous trial. Then comes the large-scale meta-analysis data, not prospective, not controlled, but still in large numbers, all showing that the various components in the red wine polyphenols do contribute to a reduction of mortality. The quantification of it is very interesting because the average reduction for each 100 grams was approximately 5%, 6% for fruit alone. But if you came to the 5 servings, it stopped being beneficial. That's nicely shown on this here slide. The red arrow shows exactly that at that particular point the benefit is not to be augmented. I don't know what that means, but it means to me that it is feasible for people to actually achieve these kind of data. So summing up, I am propagating food medicine like Hippocrates did, like many other people did. I think that the characteristics from polyphenols can be used as preventive and as pro-integrity of the endothelium, probably as early as our colleagues from the pediatric cardiologist ask us to show them, by the various factors have been enumerated on your left-hand side. There is further research to be done and ongoing to actually use it in so-called secondary prevention. Shall we say, the areas of the coronary artery that we in the cath lab often see as being normal between lesions. In fact, if you provoke these vessels, there are very great degree of abnormalities in the entire coronary tree. So I think with some further work, therapeutic and plaque regression can be achieved and the rest of the coronary artery tree properly treated. My recommendations, therefore, today, without having all the evidence of the previous speakers or of those in the audience who feel that they have the evidence, but I am a doctor. I have to talk to my colleagues. And I would frame them as follows. You either consume and strictly follow the real Mediterranean diet, as Raphael has argued, and you are sure that at least 2 to 4, preferably 4, tablespoons of virgin oil a day are contributed, and I've tried that type of thing on my patients. And in the north of Europe, you would not very readily, get a Mediterranean type of diet, or add virgin oil, olive oil. Horrible. So the recommendation by Sturg in the Predimed trial, and the recommendation by Caterina may very well be logic, but in large parts of Europe, they are not feasible. Therefore, an alternative could be, at the choice of the individual, a daily diet of his choice, with at least 5 to 6 servings of the appropriate fruits and vegetables, as was shown in the other 2 trials, EPIC and the Wang study. 600 grams a day of vegetable and fruits. You try it, you go to the market every day, and you pay for it. It is not easily achieved. Or, and that is the third option, if these strict conditions cannot be achieved, then you may take your own diet, but you have to supplement either red wine, as was argued by Dr. Korder some time ago. Now I think he is a little less provocative in that sense, but there are others that take that overview. Or you take the polyphenol mixture that has been obtained out of red wines in powder form, and you take 2 capsules of 500 milligrams to replace the red wines as a source of the polyphenols. That's what I would recommend today when a clinician comes by and says, you are a cardiologist, I hear this story, what should I do? Take the Mediterranean diet. It is very clearly demonstrated, difficult to achieve. Or take the vegetables and the fruits, very easily obtainable, but not inexpensive. Or take the red wine, or take a powder from the red wine. Thank you very much.
Well, thank you very much, Paul.